Okay, guys, let's go ahead and get started on this. For those of you who weren't here for the first lecture and the introduction, please note all of this, particularly the self-studies. And there are a couple more in this block that you need to do: temperature regulation and review of the thorax. Dr. Wilson will talk to you about the thorax. All right. A quick question. You guys should be used to this. It is relevant, I assure you. You have a molecule S. We could call it Ca if you wanted. And it diffuses 1 micron in 5 milliseconds. How long will it take to diffuse 10 microns? Who says 5? Very good. Who says 50? Very good. Who says 500? Very good. So it is not 5 times 10. It's not 10 times longer, so 10 times the time. It is 5 milliseconds times the distance squared. So if I want to go 10 times farther, I have to square that, and it is 500. 5 times 500, not 5 times 10. Okay? Okay. So we need to keep distances of diffusion short. You guys know that muscle cells are very big. They conduct action potentials, amongst other things. And so you have to do things to those cells to minimize the distance of diffusion, because they're big, but the distance of diffusion has to be small. Muscle cells are very good at that. So let's talk a little bit about cardiac muscle. It is what we call a syncytium, okay? It is, each cell is about 100 microns in length and about 20 microns in width, roughly, okay? Those are very rough dimensions, okay? And when we say they're a syncytium, what we mean is that they are connected in such a way that although they are separate cells, they act as one, okay? So the reason for that is because they are connected at what are called intercalated discs, all right? There are 2 types of connections in the intercalated discs that we're concerned with. One is the desmosomes. They are anchors. So they anchor the cell membrane of cell 1 to the cell membrane of cell 2, and make it very hard to separate them. And we have gap junctions, which we very briefly covered in the synapses lecture. These are what we call electrical synapses. They are literally 2 hemichannels that come together to form one channel that connects the cytosol of cell 1 to the cytosol of cell 2. So this allows ions to flow. So you have electrical communication, and nutrients and metabolites and water will flow, okay? So in many ways, although they are 2 cells, they act as one, okay? And specifically, when I stimulate an action potential in one, it will lead to an action potential in the second one, almost as if it was part of the same cell, okay? And we say that these gap junctions have no synaptic delay. That differentiates them from chemical synapses that you may see at a neuromuscular junction, okay? There's no delay where it's a direct communication and your ions are just going through a low resistance channel, okay? So when we say it's a functional syncytium, you may conclude from that if I fire an action potential in one, I'm probably firing an action potential in all of them, okay, eventually. And that's what we mean by the spread of an action potential. It spreads from cell to cell, cardiac cell to cardiac cell, through these gap junctions, through these electrical synapses, okay? So if we look at a typical cardiac action potential, it is different from the ones that you have been exposed to this point. We do start at a resting potential of about -90, which makes it roughly the same as skeletal muscle. And when the transmembrane potential increases, it peaks at about +20 or +30, somewhere in that area, very similar to a skeletal muscle synapse, okay? However, you will note that unlike a skeletal muscle action potential or a neural action potential, which is like 1 or 2 milliseconds long, this one is 250 to 300 milliseconds long. And the reason is because of this long plateau phase that you see right here. Does anyone know why cardiac cells have a plateau phase? What ion channel is responsible for that? What type of channel? What ion is responsible? Is coming across the membrane at that point? Calcium, excellent. So I asked you a couple questions at points during the musculoskeletal block. What would happen if you had calcium entry through a channel during the repolarization phase of a neural action potential? You guys know that it lengthened that action potential. Well, this should tell you that there's a lot of calcium coming in. And so the calcium is coming in, depolarizing the membrane. At the same time, potassium is trying to repolarize it. And what you get is a balance between the two, and you get this plateau phase before the potassium finally wins and you get repolarization. Lecture next week, we'll go over that in enormous detail, okay? These propagate via gap junctions from cell to cell. The calcium that comes in through that plateau phase causes calcium to be released from the sarcoplasmic reticulum. It is a different mechanism from skeletal muscle. The calcium influx is necessary. Dr. Ramos-Franco will talk to you about that, and I will talk to you about it. It is called calcium-induced calcium release, and that causes contraction more or less like skeletal muscle. The myofilaments bind, troponin C binds calcium and so on, okay? Here, this diagram, you want to pay attention to. We've already seen it in segments in the last lecture. And remember, in the last lecture, it was real data. This is just idealized data. But there are convenient things about doing idealized data. So let's take a quick look, a close look at this. It's called the Wiggers diagram. We're going to spend some time on it, okay? Because it does a wonderful job of diagramming out the cardiac cycle. And you should know it. You should know its features, okay? You should predict what changes may take place in it in response to changes in the physiology and pathophysiology of the cell, okay? And so pay attention to it. And it's going to keep coming up. It isn't like, you know, this is going to be your only exposure. I'm just pointing that out now. So we have time on the x-axis, okay? And on the y-axis, we have a variety of measurements that are all done at the same time and that all correlate with one another that give you an idea of what's going on with the heart during this time, okay? We have pressures for aorta, the left ventricle, and the left atrium. So this diagram is for the left side of the heart, and a typical Wiggers diagram will be of the left side. How do I know that looking at the pressures? Given what I told you in the last lecture. What's the peak pressure in the pulmonary vasculature? It's about 20 to 25. The peak pressure in the ventricle, about 120. So you guys know systemic pressure, normal pressure, 120 over 80. And so the pulmonary vasculature, the peak and the diastolic pressure are lower than that, okay? Because the vessels are more compliant and they stretch, it's a low pressure, high compliance system where you hold that volume at a low pressure, okay? So you know this is the left side because the pressures are there. They peak at 120, not 25 or 20, okay? We have the left ventricular volume tracked over time here. We have the EKG or the ECG, depending upon your preference. I think most people say EKG now. For some reason, I always pop up with ECG. And we have heart sounds, okay? And these are all on the Wiggers diagram, and they all tell you something about the cardiac cycle and where you're at and what's happening, okay? So let's go through this. And I like to start at that point. So what's happening here is we're entering a period of diastole, or we're in a period of diastole, where the ventricle is relaxing, and you will note that the ventricular pressure is dropping. So your ventricular pressure is dropping during this period as your ventricle relaxes, and as it relaxes, the volume, well, note that the volume stays the same here. I'll cover that in a minute. But the pressure is definitely dropping as the ventricle relaxes. Now, let's talk about the volume. The ventricle and the pressure in the ventricle drops, and finally it drops below the left atrial pressure. So now the left atrial pressure is higher than the left ventricle. It is not much higher, and if you were to do the measurement, you might not be able to distinguish between the two, but it must be higher. So this exaggerates the difference a little bit for effect. But nevertheless, it's a good exaggeration in that it stresses the concept, okay? So the pressure in the left ventricle drops below the pressure in the left atrium. And what happens at that point is your left AV valve opens. When the pressure behind the valve exceeds the pressure in front of the valve, blood flows from high pressure to low pressure through the open valve. Up to that point, it was closed, okay? So the valve is now opened as the pressure drops below the left atrial pressure, okay? Now you will see that blood flows into the ventricle and the volume increases, so we call this ventricular filling. And again, this is all during diastole, okay? So as the ventricle fills, you will note that eventually the ventricular pressure and the atrial pressure both start to go up because we're increasing the volume and it's starting to stretch the walls, okay? And the more the volume increases, the more they stretch, all right? Eventually, we come to the point where we get this little hump in the left atrial pressure and in the left ventricular pressure. That is due to atrial contraction. So we're getting an increase in pressure in the atrium due to muscular contraction in the atrium. And that is forcing blood into the ventricle. Our ventricular volume is expanding a little bit more, and that increases the pressure in the ventricle a little bit more, okay? We call that atrial systole. It is during ventricular diastole. If I ask you about systole and diastole, I mean ventricular unless I specify otherwise. But technically, there is an atrial systole, and it is when the atrium is contracting, okay? So the atrium contracts, that's over with, and now the left atrial pressure drops as blood continues to flow into the ventricle. Our left ventricular pressure rises, and our ventricle is starting to contract, and that really makes it rise. And once that happens, the pressure in the ventricle exceeds the pressure in the atrium. So now the pressure in front of the valve exceeds the pressure behind the valve. And what happens at that point is the valve closes. So the mitral valve is a one-way valve. All the cardiac valves are. They only allow blood to flow one way. Now you know blood flows down a pressure gradient. The pressure's higher in the ventricle than the atrium at this point. It wants to flow back into the atrium. The physics says go back into the atrium. The valve sets up a barrier that prevents that from happening, and a normal valve will prevent it from happening. So your ventricle will remain filled as contraction takes place. The volume will not go back into the atrium unless the valve is insufficient, okay? The ventricular pressure, you'll notice that the pressure drops to about 0 before it starts to go up. I should have pointed that out. There's our atrial pressure, and there is our valve closing. And the valve, the pressure continues to rise as the ventricle contracts. And eventually what happens is the pressure exceeds the pressure in the aorta, and now the aortic valve opens. The pressure behind the aortic valve on the ventricular side exceeds the pressure in front of the aortic valve on the aortic side, and blood flows into the aorta and it is ejected into the aorta, okay? When your ventricle is contracting, that is systole. When your ventricle is relaxing, that is diastole. And all this is a part of systole, that ejection phase, okay? That period where both valves are closed, the mitral valve is just closed, the ventricular pressure is rising, the aortic valve is closed, is called the isovolumetric contraction period. You know the volume is the same and it is not changing. And the reason we know that is because the valves are closed, so no blood can get in or out, okay? After the ventricle begins to relax, the pressure falls, and our aortic valve closes as the pressure in front of the valve exceeds the pressure behind the valve. When the aortic pressure is higher than the ventricular pressure, as the ventricle is relaxing, the physics says go from high pressure to low pressure. The blood wants to flow that way. Your aortic valve sets up a barrier that prevents that if it's functioning normally, okay? So it is closed at that point, and ejection is stopped, okay? That period is called isovolumetric relaxation. Isovolumetric, both valves are closed, and the volume cannot be changing, okay? At least not due to additions or subtractions of fluid, okay? Good, not normally. All right, what else did I say? Okay, let's do the EKG now that we've gone around the cycle. Our EKG has a P wave, a QRS complex, and a T wave, okay? So the P wave, you will notice, correlates very nicely with this increase in left atrial pressure. And the reason is because as your muscle contracts, as depolarization takes place in your atrial muscle, the action potentials start in one spot, the SA node, and they propagate in a wave of depolarization as one cell after another depolarizes. During that wave, if you measure the electrical potentials between two electrodes on the outside of the cells, you will see a potential difference very similar to what you see on an EMG that we just covered in the last block. The EKG is an EMG for the heart, okay? So when half the atrium is depolarized and the other half isn't, there is a voltage difference between the two electrodes, and that causes a deflection on our EKG. This deflection is due to depolarization of the atrium, and you will note that that takes place during or just before this increase in atrial pressure where the muscle is getting around to contract. Muscular contraction is a little bit slower than depolarization, okay? The QRS complex correlates nicely with the sharp rise in ventricular pressure, and it is generated by depolarization of the ventricles in the same way that the P wave is generated by depolarization of the atrium. It's a wave of depolarization that is propagating through the heart, and it's setting up a potential difference between two external electrodes, okay? And that correlates very nicely, very closely with where this valve closes, because that's about when your ventricular contraction is starting. And that takes place during ventricular systole, okay? So you have this action potential depolarizing one cell after another, one segment of tissue after another, as it spreads through the entire ventricle. And eventually that depolarization ends and all the cells are depolarized, okay? Basically, all those cells are in the plateau phase of their action potentials. Calcium's coming in, contraction is taking place, and the cells are, and the voltage is hanging up. If you look back at the action potential that I showed, it's in that plateau phase, all of them are, okay? And then repolarization starts to take place as one cell after another comes back down to the resting potential. And that propagation of repolarization as cell after cell after cell repolarizes is represented by the T wave. And what is taking place during that time, or what is starting to take place, is muscular relaxation, and the pressure in your ventricle is starting to go down, and your muscle is relaxing, okay? So you can see how each one of these correlates with a certain segment of the cardiac cycle, and how you can look at it and figure out what stage you're at depending upon what you're seeing on the EKG. Let's look at the heart sounds. We have S1, scientifically known as lub, and S2, known, as dub, okay? No Latin there that I know of. You'll notice that that sound takes place right about where that AV valve closes, pretty close. And in fact, it is a result of that closure, okay? Your ventricular tissue makes noise when blood suddenly decelerates or accelerates. And that is heard in your stethoscope as lub. So when you hear lub, S1, that means the mitral valve is just closed. When you hear dub, S2, that correlates very nicely with just about the point in the Wigger's diagram where you know the aortic valve closes. And so you hear dub and you know your semilunar valves are closing. The same things are going on the right simultaneously. So lub would be the aortic and pulmonary, the mitral and the tricuspid. And dub would be your aortic and your pulmonary. On this diagram, it's aortic, okay? S1 and S2, so you're listening and you know what phase of the cardiac cycle you are in. And if you hear an abnormality, you can tell what phase the abnormality is taking place in. And that will give you a hint as to what the diagnosis may be. And we'll practice that a little bit, and you'll practice it a lot next year. Okay, so for ejection fraction estimated at 5 to 10%, normal is about 60%. If you look at that diagram, I had the ventricular volumes on it, you could see that we went from about 130 down to about 80. Give or take, that's about 60%. So obviously, that's 5 to 10% is abnormal, and it suggests that her stroke volume is probably low, which, we looked at the cardiac output, we looked at the heart rate, we could kind of figure that. Okay. So that is a pretty good indication that we're looking at disease here, okay? Okay, so I asked you guys which insufficient valve you thought you were hearing during your holosystolic murmur. Now that you can look at the Wigger's diagram and you know where systole is and you know where diastole is, and you know what an insufficient valve is, which valve is it? Mitral, good. How did you know that? That is right.
Because that's when, during systole is when the mitral valve is closed, so that would be the blood flowing back through it.
Could not have said it better myself. That is exactly what I would have said. During systole, this valve is closed, and there should be no flow through that valve, no normal flow. So you're going to hear an abnormal flow through that valve if it's insufficient during systole. During systole, the aortic valve is open anyway. Who cares if it's insufficient? I don't care if it leaks when it's open, because I'm forcing blood through it anyway. It only matters if it leaks if it's closed. So the mitral valve is closed during systole. The aortic valve is closed during diastole. So that tells you which valve you're hearing if it's a holosystolic murmur, okay? Good. And there's our diagram. There's systole. There's the closure of the mitral valve. That's when you hear an abnormality in a closed valve, okay? Pressure is higher in the ventricle, lower in the atrium. Blood wants to flow from the ventricle to the atrium, and it is not being prevented by the insufficient valve, and so blood leaks through. If it's open, who cares? I mean, if it's insufficient and you're in this phase, who cares? Okay, good. I did that, come on. This is the disadvantage of animations. There we go. All right. You're aware of the fact that membrane voltage is the inside of the cell relative to the outside of the cell. The SA nodal pacemaker is on the bottom here. It is the pacemaker for the heart. So this is our ventricular action potential. This is our SA nodal action potential. The AV node looks very similar to it. Okay, now you will notice our resting potential at about -90 in a ventricular cell, and it is relatively steady. In an SA node, that, quote, resting potential, unquote, is not steady. It is rising. What happens is it rises until you hit the threshold potential. Once you hit the threshold, you fire an action potential. And then that action potential repolarizes, and then this membrane voltage on its own rises and spontaneously fires again. That does not happen in a normal ventricular cell. It has to be stimulated, otherwise it just sits at rest, okay? So this is why the SA node sets the pace for the heart, because it depolarizes and it hits threshold, and it causes all the other cells to depolarize and hit threshold after that. The action potential propagates from cell to cell, and it stimulates them to contract, okay? So because we have this spontaneous depolarization going on, it sets the heart rate. The heart will beat every time you hit threshold. If I want to alter the heart rate, I'll increase the rate of that rise, and I'll hit threshold more frequently over time. If I want to slow the heart rate, then I'll slow the rate of rise in the resting potential, and I'll hit threshold less frequently over time, and my heart rate will be slower. And that's how the heart works, okay? You should be aware of these concentrations. I know that I said that 2 blocks ago. You had to know them for the last block, and now I'm telling you, you have to know them for this block. Do be aware that that calcium varies. It will be higher than 50 nanomolar when your cell is contracting, but it sits at 50 nanomolar to 100 nanomolar or 120 or so at rest, depending on who you talk to, okay? That level is maintained through the auspices of primary active transport and secondary active transport. It's like a bad penny, it keeps coming back. We have calcium pumps in the cell that pump calcium out of the cell, either out of the cell or from the cytosol into the sarcoplasmic reticulum where it accumulates, okay? And that keeps that calcium concentration low. We have the sodium-calcium exchanger, and we have the sodium-potassium ATPase. The sodium-potassium ATPase maintains this gradient for sodium and potassium across the membrane, and that gradient is used to pump calcium out of the cell through the sodium-calcium exchanger. Sodium goes down its gradient from high concentration to low concentration, from outside to inside, and as that happens, calcium is transported out of the cell, up its gradient, and into the extracellular space, okay? And that is what we call the normal forward mode of the exchanger, okay? It is a reversible process. It is debatable about whether it actually ever operates in reverse. But for sure, you should remember that it pumps calcium out, okay? You guys know this now. Ion gradients, primarily potassium, establish the resting potential because the permeability to potassium at rest is higher. Its equilibrium potential has the greatest effect on the resting membrane potential. EK, what is it? Negative 95, good. What happens if there's no ATP as in a myocardial infarction? What happens to the sodium in the cell, up or down? Up. What happens to the potassium in the cell, up or down? What happens to the resting membrane voltage? Becomes less negative. And in fact, it migrates towards 0 as all your ion gradients collapse. If you've got no potassium gradient, then you can't have a resting potential and you can't fire an action potential. Okay? So if my membrane potential in the area of the infarction is 0, what does that tell you about the force of contraction in that area? Bad things. If I'm at 0, or if I'm anywhere close to that, my sodium channels are inactivated, and they cannot be opened, and I cannot fire an action potential. And if my action potential normally has to go through there, it means bad things, okay? And that would be one reason why you get arrhythmias, cardiac sudden death, and heart attacks, okay? So not entirely irrelevant, I would say, okay? The ventricular action potentials and the ones that look like them are called fast action potentials because this rise is very fast. This is called slow response action potentials. This rise is actually slower. We will talk about why that is next week, okay? So let's quickly go through how the action potential propagates through the heart. We start at the SA node. It's about the size of a piece of rice, and it sits right in the cleft between the superior vena cava and the right atrium, okay? And in that area, you have these spontaneously depolarizing cells. They throw action potentials, and every action potential results in a heartbeat. So we hit threshold, our action potential propagates. It propagates through the atria, both the left and the right. And it does that in about 100 milliseconds. And during that time, if you look, we have a little ECG down here. These are the action potentials lined up in time. So you'll notice that my atrial action potential comes a little bit after the SA nodal action potential because it's propagating from the SA node through the atrium. And that's where it got to this point, okay? And you will note that that correlates very well with our P wave down here on the ECG. Our atria are depolarizing. We have a wave of depolarization going through them, and it causes a deflection on the ECG, okay? We then go to the AV node, and that is a very small piece of tissue that is the only piece of electrical communication between the atrium and the ventricles in the normal heart. In a normal heart, all of the propagation must feed through that area, okay? The action potentials look very much like they do in the SA node, and the propagation relatively slow, and it causes a delay where you'll see the action potential go in, but you won't see it come out for a certain period of time because it takes a while to get through the AV node, okay? And when it finally comes out, after this PQ interval right here, it finally comes out, our ventricles begin to depolarize, and that correlates very nicely with this QRS wave, okay? Our ventricles are depolarizing, and we have this wave of depolarization going through the heart. It propagates down the bundle of His in the area of the septum and out through the Purkinje fiber network along the interior, the endocardium, okay? And it propagates very rapidly out and around, and then it spreads gradually through the ventricular wall, okay? From inside to outside, and you can see these action potentials lined up here as we go from inside to outside again during our QRS. All right? After that, repolarization of the ventricle starts to take place. See this? The repolarization correlates pretty well with that T wave. So we have a wave of repolarization happening in the ventricle, and that generates a deflection on our ECG as well, okay? This is our patient. Those spikes that you see are pacemaker spikes. If you look at her radiograph of her chest, you can actually see leads, okay? Actually, those are ECG leads, but she's got a pacemaker. And note this right here. See that spot? See where each one of these follows right after a pacemaker spike. So the pacemaker says depolarize and contract, and we get a deflection on our ECG that follows that because our pacemaker is setting the pace. Look what happens here. The depolarization comes before the pacemaker spike. Pretty weird. That means that that typically means that someplace other than the SA node and someplace other than the pacemaker, in this case, the artificial pacemaker, has decided to depolarize on its own. And once one segment of tissue in your heart abnormally decides to depolarize, they all depolarize. They're all connected together, inseparable, they're family, okay? And so that is one way that you could get an arrhythmia. Because, you know, you can't have depolarization taking place willy-nilly. It has to take place like I diagrammed it. And it has to be coordinated. You have to have your atrium contracting on time. You have to have the spread through the ventricles exactly right so that you get this nice smooth contraction that's on time. And then the repolarization has to hit such that the walls relax and you fill on time. And if you disrupt that and things just start depolarizing when they want to, you get an arrhythmia, okay? And so this is an example of what can happen. If there were no pacemaker, that would be an abnormal beat, okay? That would be something that shouldn't be there. So this is an example of the physiology that I just showed gone bad, okay? And we'll leave it at that, all right? Great. Thank you. That is it. We ended early, so you guys owe me time. Any questions before I go on? That was a lot really quick. But you'll notice that we have an ECG lecture. We have an intro to arrhythmias and antiarrhythmic drugs. We have a cardiac action potential lecture. You know, these were just introductory. We're going to be hitting all that stuff in detail. So don't worry excessively. Okay? Close it after you stop the recording. That way, because when I close it, they'll be able to see the name.